मारे बोल रहा है, ये म्यूट क्यों नहीं हो रहा है?
Sir, good evening.
Good evening.
Good evening. I will just.
How are you?
I am
Hey, sir.
fine. I will start the screen.
Enjoying the holidays.
नहीं, add the word enjoying a well-deserved break.
Yeah, that's true, sir. एक्चुअली आपको अभी एक बीईपी का नेशनल ऑडिट जो हो रहा है उसका मीटिंग हो गया अभी।
अच्छा,
तो आप उसमें एनरोल्ड है क्या?
अरे मैंने मैडम को 2 बार रिमाइंड किया पर मैडम ने मुझे इंक्लूड ही नहीं किया उसमें। मैं एक बार फिर रिमाइंड करता हूँ मैडम को।
एक्चुअली गौरंग शाह सर का भी नाम नहीं दिखा।
अभी मैसेज करता हूँ मैडम को।
हाँ, क्योंकि वो सिर्फ इथिकल कमेटी का परमिशन लगता है।
हाँ।
वो एक ही चीज है जो लगती है, और लास्ट सितंबर से लेकर आप तक के आप ऐड कर सकते हो ऑलरेडी जितने हो गए उतने।
ओके।
जयपुर से 100 केसेस ऐड किया है अपने इन्होंने, क्या बोलते हैं, शिवम सर ने। बाकी बहुत सारे लोगों का है, अपने पास भी से 20 केस, टोटल 20 केसेस हो गए। एक्चुअली क्या है कि नंबर ऑफ TURPs नाउअडेज जो बोलने वगैरह हो जाता है, मेडिकल ट्रीटमेंट बहुत सारी चल रही है, तो थोड़ा केसेस कम हो रहे। 1000 का टारगेट है सर दिसंबर तक। तो मुझे लगता है ऐड होने में कोई हर्ज नहीं, आप देखो।
नहीं होना ही है सब। जब अपनी जजे में बात हुई थी
जी सर,
तभी
जी
मैंने
सर।
एक बार और उसके बाद एक बार कुछ 20 दिन बाद वापस मैडम को रिमाइंड किया था एक बार। अभी वही उनको ही मैसेज टाइप कर रहा हूँ।
चलेगा। गौरंग शाह सर को भी बोल दे तो उनका भी सेंटर ऐड हो जाएगा, पता नहीं।
हाँ, क्या क्या चाहिए मेरे को जरा बता देना
सर। एथिकल कमेटी का परमिशन चाहिए।
हाँ।
तो लास्ट सितंबर से बीईपी का जो ऑडिट चल रहा है, नेशनल ऑडिट,
हाँ,
तो उसमें अपने सेंटर को ऐड कर सकते हैं।
ओके।
तो सुजाता मैडम के पास है उसका जो मेन।
करेक्ट।
उनसे एक बार बात करके ऐड कर दे तो चलेगा सर।
हाँ, या उसने मेरे को मैसेज भी भेजा था।
जी सर।
हाँ, तो मैं उसको कर लेता हूँ।
चलेगा सर।
अभी देखते हैं कितने लोग ज्वाइन किए। 5 मिनट में चालू करते हैं।
जी सर 25 है
sir.
Yeah.
Gaurang sir, your name is not visible. You are joining as a name of Samsung. Hello sir. Hello sir.
Hello. Sir, Venkat Ji and Pankaj,
हाँ जी सर.
today now we have got only X-ray and pathology specimen type.
Okay.
So we will just show them.
Right.
We will describe it, and then you people, everyone can ask them questions like in exam.
Sure.
So I think 4 students and 4 sets like that we have done it. So who are answering today?
So only three volunteers for today.
Okay, then the last one we can ask all 3 of them about that. The last set, or if the time permits, more also, whatever is there. Paras, you have got extra, na? With you?
Yeah.
Okay, just we wait for 2 to 3 minutes. At 9:10 we start.
Okay, sir.
Sir, whom should I make post? Who will be answering?
Pardon?
Make Dr. Ojas, Dr. Amit, and Dr. Abhishek as co-host with Paras.
So all the MCH exams are over? Gite sir,
Sir,
theory exams, how many centers? All MCH exams are not together, na? All different universities.
no, sir, they are at different time and different dates.
Okay. So Maharashtra is on what, 26?
26, 27, 28 and 29 something ऐसा कुछ है. एक दिन गैप है शायद मेरे ख्याल से.
हाँ, एक दिन gap. I think 26 to 1st of August. 1st August is the last.
Yeah. Yes, sir.
Yeah. And the practical will be 15 days after that.
Practical will be in August probably.
Okay. Any news about DNB? JJ का कुछ आया है? JJ center or what?
हमने मांगा तो था सर, अभी इस साल देखते कोशिश करते.
Fine. The students were telling me that
Yes, sir.
they want to continue with the short cases, like already major cases we have already completed, but they were saying that every Tuesday you continue with the short cases, like 2 or 3 cases, within like in half an hour, how in the exam we ask them questions right up to the management, not to go too much in history and examinations and all. So that is one thing. And they are saying on Friday you take us on like instruments, viva, pathology, urodynamics and other things. So
two short cases and 2 ward round. Usually they will start with some short history and local examination, and directly discussion will be on the planning of management and management itself. तो वो हिसाब से ही करे वाला अच्छा रहेगा. लॉन्ग केस तो ऑलरेडी हमने लास्ट सेशन में 2 बार किया है.
Long cases means we'll see, even if we take a short case, it is going to help them in a long case, because they ultimately, so we finish fast. But they are saying on Friday you keep tables and OSCE and viva and all these things. So what is your idea?
Table viva में this year they have added subspecialty, recent advances, research methodology. These are the 3 points. So
no, but whether we should go out doing it on Friday or on Tuesday only?
Sir, it is depend upon the students what they want. अपने तरफ से कोई problem. If they want Friday and Tuesday, we are ready. If they want only Tuesday, that also fine. अपने तरफ से कोई issue नहीं sir.
Okay, so please all the students, you give your opinion whether you want only on Tuesday or you want Tuesdays and Fridays to separate before your exam. Let us know, so accordingly we will arrange it. Right? Okay.
Yes, sir.
Sir, can we start now?
Yes sir, 31 now we can start.
Yeah. Who is the first candidate to answer? Hello.
Hello. Yes, sir. Okay,
Who is
Amit
the
Kumar.
first candidate? Amit is answering.
Yes, sir.
Okay. So Amit, you have to see the X-ray and tell us what you are seeing in that X-ray, and then we'll ask you the question.
Sir, it is a X-ray of pelvis, well exposed but not poorly centralized, showing bilateral iliac bone and a pubic and ischial rami and sacrum and lumbar L4, L5 vertebrae and femur head with with calculi in the prostatic urethra.
Fine. So how this patient will present?
This patient will present with the acute urinary retention or pain while passing the strangury or dysuria or maybe hematuria, sir.
And if he's passing urine, it will be a normal flow or decreased flow?
Decreased flow, sir.
Okay. Gite sir.
You call it prostatic urethra or bulbar urethra?
Sir, it is near the inferior border of the pubic rami, so it might be the prostatic urethra.
I don't think the prostate goes below the inferior pubic ramus. What do you feel, Dr. Gite? What will you call this?
This is most probably it is like a membranous urethra. What you are saying
Even
is
I feel so. I don't think it will be prostatic urethra.
correct.
Usually the prostatic urethral stones are superimposing with the symphysis pubis.
Precisely. So they can be
precisely.
seen as a shadow between the two sides of the pubic symphysis bone.
Yes, sir.
Yes.
This is probably if the prostatic urethra is dilated, then that may be inside that recess of para utricular recess में रह सकता है, लेकिन it is in the bulbomembranous area, looks like.
Precisely.
Okay.
And presentation, it is not necessary every prostatic urethral stone cause retention. So patient may present with severe voiding symptoms associated with some storage symptoms also. He may present with acute urinary retention. He may present with chronic urinary retention. He may present with hematuria, then suprapubic pain. He may present with back pain. He may present with renal failure, signs of renal failure. So anything can be possible. So we have to, when question is asked how he present, then it is an infravesical urethral obstruction. You have to take into consideration everything, that is dilated, distended bladder, distended kidneys, back pressure changes, renal failure, everything you have to take into consideration, and you have to give in detail about the presentation of such type of patients.
Okay.
And one more thing. Do you think that you are happy with only one X-ray?
No, sir.
Then why? Suppose there is a Staghorn calculus, and with that Staghorn calculus, one small stone, satellite stone or something stone has fallen down and it has come out.
Yes, sir. The whole
Fine.
X-ray cave be with pelvic part.
Okay. So now tell us, what are the investigations you will ask?
So I will ask for the urine routine and urine culture with complete blood count and serum creatinine. And then I will explain the patient about the condition, and then advise him for the cystoscopy and
No other investigation? No other investigation?
Amit, this is only X-ray pelvis without the part of the both femur. So it can be anything. So your answer should be like, I want to examine the patient first. Then I want to see his bladder is distended or not. Then I want to examine his both full abdomen, renal angles. Then if his bladder is distended, then you have to take care of his distension first. Parallelly, you have to send the lab also, and you have to go for investigation also. So the patient is in retention or not. Along with that, treatment of retention, treatment of infection, and further plan should go hand in hand.
yes.
So you don't want to do sonography, you don't want to do any X-ray, you don't want to do any other investigation?
Sir, I want to do a full X-ray KUB. If is there any abnormality in the X-ray KUB, then we can go ahead with the CT KUB, plain CT KUB, if any calculi is found in the X-ray KUB.
देखो, if you want to go for X-ray QB, tell X-ray QB and ultrasound. That is combination. Okay. So ultrasound will tell the upper tract status, and X-ray QB will give radiopaque densities, and both will support each other. Or you will so density will give the site of the stone, size of the stone, upper tract, dilation, everything that can be, except renal function and drainage pattern, it cannot be commented to NCCT QB. So either you have to choose one and depend it in exam. If, I will go with one ultrasound and one X-ray QB, that is also okay, conventional way for diagnosis. If you don't want to go for X-ray QB and ultrasound, stateless serum creatinine and CBC, urine routine, urine culture, as well as one non-contrast CT scan QB.
Okay.
So both can be accepted.
So now finally tell us how you are going to manage this case. Pankaj bhai, you want to ask any question?
No, I think things are going good.
Okay, so now how will you manage this case?
Sir, cystoscopy, urethroscopy with urethrolithotripsy if stone is impacted.
Amit, you said
Yes.
what is the first presentation?
Sir, if patient is in the acute retention, then I will first drain the bladder.
How will you drain it?
If per urethral stone is mobile, then by pushing the stone by inserting the catheter into the bladder, or if a gentle attempt is not possible, then putting the SPC.
Now, as Dr. Maheshwari has said, it is in the membranous urethra. It has passed the prostatic urethra, but it is in the membranous urethra. Then what are the chances? The obstruction will be where? At the bladder neck or at the bulbomembranous juncture?
Bulbomembranous junction.
Why?
Sir, it is narrowest part of the urethra, sir. One of the narrowest part of the urethra, membranous urethra.
So it will not get
Which
blocked.
is the narrowest part?
First is a navicular fossa, sir, and that meatal part.
Suppose we say that this patient has presented with retention of urine, and clinically membranous urethra, you will palpate digital rectally, you suspected a stone, you got this X-ray pelvis done, which has confirmed the stone. Now, how do you want to proceed?
Sir, I will first try per urethral catheter by push back the stone into the bladder. If with the gentle catheter insertion. If not possible, then I will directly proceed with the SPC insertion.
Yes. So with adequate lubrication, you will try to make one gentle attempt at catheterization. If it drains, very good. If not, then a suprapubic catheter is a good idea.
Yes, sir.
Right. And then once you have placed suprapubic or fully, then what would be the next plan?
So next plan will be urethroscopy and lithotripsy, sir.
What would be your energy source of choice?
My choice will be laser for the lithotripsy, sir.
Why? Why? Why you have chosen laser?
Sir, laser will be inserted through the cystoscope bridge, while that pneumatic probe will be difficult to pass through the cystoscope, sir.
Amit, you see, just saying laser will not be enough. You will have to tell which type of laser. Suppose I have only thulium laser, then what will I do?
Yes, sir.
You agree with me? You
Holmium.
don't agree with me. Not every laser
Yes.
will work on stones.
Yes, sir.
अगर सिस्टोस्कोप जा रहा है तो पाटनकर सीट के साथ तो वो सीट क्यों नहीं जाएगा? क्या प्रॉब्लम है?
What are the chances that this stone will be removed without breaking?
Sir, it will injure the urethra, sir.
No.
If,
By just giving a wash through a cystoscope, 25 French sheet. Do you think there are chances?
Sir, yes, there are chances, but chances are less, sir.
देखो, size of the beak of the seat and size of the stone.
Yes.
Okay, if you are placing a 25 French seat, then why not Patankar seat? And if you are trying to remove that stone with cystoscopy 17 French, 19 French, then it is totally depend upon the size of the stone. If it is 6.5 millimeter, 6 millimeter stone, it can be just by giving wash, it can become out.
Yes, sir.
But if it is more than that, the window of that big size, then how it will come out? It will not come out.
Yes.
So seeing
So
this
you have to
X-ray, what
explain
is
it.
your assumption? Will it come out or it won't come out?
Sir, it won't come out. It looks
It
like
looks fairly
more
broad.
than
It
one,
is less likely to
more
come
than
out.
1 centimeter. Yes.
Yes. Okay. Is the stone primary or secondary?
So its surface is smooth, so it might be secondary, or it can be a primary also, sir.
What is primary and what is secondary stone in membranous urethra?
Sir, primary stones are that stone that dropping from the kidney and comes into the bladder and then passes to the urethra, and secondary stones are any flow obstruction, and that stones are formed in the urethra itself. That is the secondary stones.
Amit, there are 3 types of stone. One is primary, which is developed inside the bladder. One is secondary, which is secondary to some cause. And third is migratory.
True.
Yes, sir.
So
then
stone coming
answer the
from
question
kidney
of
is not a
Pankaj sir.
primary stone.
Okay, sir.
So what would be the causes of secondary stone at this site?
So stricture of the urethra, sir.
What else?
Or meatal stenosis, sir.
Meatal stenosis से यहाँ क्यों बनेगा सब?
Stricture urethra.
Can it be a stone in a urethral diverticulum?
Yes, sir.
How will you confirm that?
Sir, by doing the RGU, sir. RUG or RGU, sir.
Right. So commonly this patient will not present with obstructive symptoms. This patient will present with a long history of say repeated infections.
Yes, sir.
And you will confirm it with a retrograde urethrogram. Perfect.
Another indirect way is catheter goes easily.
Yes, sir.
Because it is outside the tract.
Okay,
मेरे ख्याल
fine.
से
And then we should go ahead now second with the pathology specimen.
Yes, sir.
Okay. Paras, change. Paras,
Yes, sir. Yes, sir.
yes, Amit,
This is
describe
the
and yeah.
formalin containing jar contains the tissue chips from the TURP.
Amit, please tell us in a proper sentence, You said that it is a formalin jar, correct?
Yes.
Containing multiple
canoid
prostatic-
shape.
It is
canoid
it is the TURP chip or is the prostatic chip?
A prostatic chip, sir.
Yeah, and how it
Done
has
by-
been by
Done by TURP, sir.
by
Monopolar
TURP.
or bipolar.
Okay, fine.
So during the instrument session or during the specimen, definitely one can have such the things related to the prostate and TURP. It can be a resectoscope, it can be a cystoscope. They may ask to assemble the TURP set. Then they may ask the number of types of the instruments, how you prepare the trolley for TURP. Then the question may be on the quadries. The question may be on the type of TURP, type of resectoscope, name of the resectoscope, then irrigation fluid used, height of the irrigation fluid used, then amount of sodium loss per liter of the
Yes,
fluid.
sir, why don't we ask him? all
सर
the
ये
questions?
एक फिक्स प्रोटोकॉल है, ये ऑनलाइन एवरेज मिलता ही है सबको. तो
so let us
ये
ask
सबको
him.
टिप ऑफ टंग रहना चाहिए, इसमें कोई कंफ्यूजन नहीं रहना चाहिए. तो एक एक क्वेश्चंस मेरे ख्याल से पूछ सकते.
Yeah, so you started, na?
So if who is
My first
answering?
question, yeah, so my first question will be, what is your protocol with the size of the prostate? So you, depending upon the size of the prostate, how will you decide what line of surgery you will do? Just give us in short.
Sir, if size is less than 80 gram, then the option is monopolar or bipolar TURP. If more than 80 gram, then open prostatectomy or holmium fiber, holmium enucleation or thulium enucleation of the prostate.
And if it is 300,
such the open prostatectomy or holmium enucleation.
see, I don't know. Maheshwari ji, now what is the latest protocol? I believe that they are saying that more than 150, 180, ideally you should do open.
No, sir, there is no such protocol. For large prostates, enucleation can be done. But, Amit, 300 gram enucleation is something really very, very difficult.
Okay.
And very few people will be able to do it. I would prefer you saying open prostatectomy by Millins or Freyers. Vis-a-vis, if somebody wants to do a minimally invasive procedure, then robotic or laparoscopic simple prostatectomy can be done.
Yes.
Don't talk of enucleation for a 300 gram prostate.
Okay.
If you go at literature, people have described enucleation even for 650 gram gland. But these are very rare situation and rare people will be able to do it.
Okay, sir.
So even in my hands, I do not advise HOLEP for anybody more than 200 to 20 gram because it's too long a procedure. It takes a huge time for morcellation, and probably a simple open surgery will be better than making such a big struggle for a 250 gram gland.
Okay, so you know what answer to give in exam.
Yes,
Fine.
sir.
So
Okay.
in exam, you have to make the examiner happy. So like
Yes.
by saying it is depend upon the size of the gland, associated the general condition of the patients, and is he on some blood thinners or not, then availability of post-operative backup, and my experience.
Yes, sir.
And
So
associated
if it,
conditions like large stone or diverticulum.
Yeah.
Okay.
Fine. So name the instruments you will use for this.
So for this, I will use the Iglesias continuation irrigation sheet with monopolar or bipolar cutting loop.
Amit, what are the instruments you will use? First, you'll like to do a cystoscopy.
Yes, sir. Cystoscope.
What are the instruments you'll use?
A cystoscope sheath, cystoscope. Then
Cystoscope sheet you'll use.
what, sir?
25, 20, 22, 17, 19, 15. Which one you'll use?
Amit, just remember if you are doing a TURP, how will you prepare the trolley? So you first have to do a scopy. So scopy
Yes,
will
sir.
be done with 17 French or 19 French sheath with 0° and 30° telescope with some that light source, light cable. This is and irrigation. So this
And
is
the
for
bridge.
cystoscopy
And
and bridge
you will have.
and bridge.
And the
Then
so
if
camera also.
you
You have to say.
if you feel that there is a stricture inside,
Yes,
there may be chance. So your VIU set should be ready. Okay.
Yes, sir.
Then another is Otis instrument. Then
Yes,
another is TURP. So 24 by 26 sheath obturator, sheath visualizing obturator. Then working element. Then types of working element: thumb operated or finger operated. Unke names. Then resectoscope is rotating, non-rotating. Then loop, single stem, double stem. Then quadri wire and quadri setting and light source and cable and camera and the visualizing that TV. So ये one go में याद करते करते पूरा बोल देने का, so that उसको examiner को लगना चाहिए कि you have done it.
Yes, sir.
Plus वो अपना टमी syringe भी रहेगा. टमी syringe
or,
Tommy syringe, police
Alex,
catheter. So which size police catheter you use?
22 French 3 ways, sir.
22 French 3 ways. And how much balloon you'll inflate in this case? In this case,
Depending on the size of the prostate, sir, 30 to
this
50
case,
gram.
this case, in
30
this,
to 50 ml. Around 50 ml, sir.
okay. Now, what are the complications?
So sir, before complication, what are the fluids can be used for doing the TURP?
So distilled water, 1.5 or 3% glycine, normal saline, then 5% dextrose, mannitol.
Sorbitol plus mannitol, normal saline.
Yes, sir.
Okay. So how much ml of fluid is absorbed while doing the TURP per minute?
So 20 ml per minute fluid is absorbed.
How much there
At
is
the
a
height
drop
of
in
60 ml, 60 centimeters.
how much drop in sodium per liter of fluid absorbed?
Sir, I don't know.
How much drop in sodium per liter of fluid absorbed?
Sir, I don't know.
So 5 to 8 millimole per liter.
Okay.
How much fluid is required to have good vision per minute? Irrigation fluid.
300 ml per minute, sir.
Okay. So what are the types of resectoscopes?
Sir, Iglesias continuous irrigation resectoscope.
Abhishek, bolo.
Sir, Baumrucker's active working electrode. And sir, Nesbitt's passive working electrode resectoscope, sir.
And one more.
Sir, laser receptoscope, if you're using a hollow or a thulium laser.
No,
So
for
what
diagnostic.
is
If you're using a laser receptoscope, then a hollow set or a thulium set.
Your
What is
audio is not very clear. I can't hear what you're saying.
Sir, if you're using laser like HOLEP or PULEP, then the laser receptoscope.
No, that's fair. What I'm asking is, what is the third type of TURP resection equipment?
Bipolar resectoscope.
Bipolar.
What is rack and pinion?
वो ओल्ड इंस्ट्रूमेंट है दिखता है वो वर्ड रैक एंड पिनियन का वर्ड मीनिंग भी पता है तो उसको एक्सप्लेन कर सकते.
So, like, in city of Mumbai, when we joined urology, Dr. Phadke was famous for using rack and pinion resectoscope. And that was the only place where I have seen anybody use that. But it is different from our finger and thumb operated system. Just know about it more out of curiosity than anything else.
So
in today's time, nobody uses it.
What are the advantages of advantages and disadvantages of active receptoscope or active working element?
Sir, active working element, the resection is fast, and disadvantage will be the chances of trauma to the bladder.
Why?
Because if unknowingly we will we have not control over our finger, then it will injure the blood.
Loop remains outside.
Outside, yes, sir.
In relaxed position, the loop will remain outside.
So if that will cause the inadvertent injury. What you are telling is right, but it is due to the loop which is outside in resting place.
Yes, sir.
Then what are the advantages and disadvantages of passive?
In the passive element, the loop remain inside during the relaxed phase, and the resection is slower than the active element, and passive element is thumb operated. So during the release phase, it will cut.
Why it is slow resection?
Because
I use passive element. I do it quite fast as the finger action. It's just what you're used to it. I don't think that it is slower.
Okay.
For the person who is doing regularly, but for the theoretical purpose, cutting is passive. So speed of the resection is slightly slower. That is what can be told in exam compared to active, because in active we have every moment in your control. You have to you can bring till whatever length you can bring that active loop length or longer length, and passive you have to fix, there is fixed length. So एक बार आपने छोड़ दिया कि वहां तक क्या आएगा, उसको पीछे लेके नहीं आ सकते. एक्टिव का कैसा है कि अगर ब्लैडर नेक पे भी शुरू कर दिया और वेरू 5-6 सेंटीमीटर तक दूर है तो you can just move the assembly and it can be brought right up to the 5-6 centimeter. So active is slightly faster resection and passive is slightly slower resection. Theoretically okay, but if the person is experienced with thumb, then it can be done with equal speed and amount.
And one more thing is, I think it is little more tiring to do with the thumb action in the large prostate, because you are not tuned to do that movement with the thumb, but the finger is much easier. Second thing is the control. When you are doing the resection, in the median lobe, or you are going into the, at the 6 o'clock position, I think it is more precise. But again, as Dr. Gite said and Dr. Hiren said, everything depends upon experience. Once you have crossed like hundreds of cases, it hardly matters whether you are using thumb or whether you are using finger.
Yes.
Fine. I think Gita sir remaining, just asking about the complication. So can you just tell us the complication and then we finish here?
Complication intra-op and post-op. Intra-op bleeding, then retained tissue chips, then retention due to the clot or retained tissue pits. Then
That is intra or post-op?
that is post-op.
So intra-op you tell us, na?
Intra-op bleeding and capsular perforation and injury to the urethra or injury to the bladder, and if large median lobe is there, and post-op is there retention due to the clot or tissue bits, then urethral stricture, bladder neck stenosis. Yes.
How you will prevent bladder neck stenosis? You said bladder neck stenosis.
Sir, less resection at the bladder neck, sir.
Not less resection, but less cautery. You can resect it nicely, but you should not coagulate too much.
Yes.
And suppose patient has pacemaker, what precautions you will take? Can you do TURP or not?
Sir, I have no idea, sir.
Okay, now this boy is preparing for TURP. You are in the OT, and he has.
No, I will answer this, Hiren.
Yes,
You
sir.
can do TURP. Of course, nowadays we have got thulium and HOLEP, so that is preferred. But if you don't have that, you can ask the company people. They will
Correct.
be around.
I wanted him to tell that answer.
So company people are there. They will come and they will.
They will come. They will be there during the surgery so that they'll adjust the pacemaker.
Pacemaker, and they put it at a fixed rate, and they say that you can go ahead, but use minimum of the cautery. Means like don't use excess. So don't do too much of coagulation.
Okay.
Second question was your OT boy is putting the cautery pad. Now he's put it under the right shoulder.
Yes.
So will you proceed now?
No, sir. I will put in the near the buttocks, sir. So the distance between the arc will be reduced from the patient's surface to the cautery.
Correct.
Sir, can we do a bipolar TURP, sir, in a patient?
Yeah, you can. That was the answer actually. And also you can call for the pacemaker person. Both are correct.
Fine. Okay. I think we should stop here. Take the next two. Okay. Who is answering now?
Sir, I am answering, sir. Dr. Abhishek.
Okay, Abhishek. Paras?
Yeah.
Sir, this is an X-ray of the KUB region, sir, well exposed, and not centralized, sir. It is showing, sir, the spine. A small amount of scoliosis can be seen, sir, on the spine. Iliac bones can be seen, sir. And on the left side, sir, there is radio opaque shadows that can be seen in the occupying the kidney region and the pelvic calyceal region also, sir. Most probably this is a Staghorn calculus, sir, of the left kidney, sir.
Okay. Anything else?
Can you see little above?
Sir, can I answer?
Yeah, you can answer.
Yes, sir. So on the right hand side, also at the L2 level, we can see another radiopaque shadow. Also, I'd like to comment on the left hand side. There is a Staghorn stone, yes, but the kidney pelvic calyceal system appears lower. So this is not, the kidney doesn't appear to be in the normal position. The stone is occupying the entire PCS with the lower calyceal showing multiple secondary stones. Filling up the entire lower calyx, and this this appears to be a Staghorn stone in a ectopic kidney or a lower as in ectopic kidney or a pelvic ectopic kidney, sir. In ectopic kidney, slightly lower down. On the right hand side, there is a stone. There's another radio-opaque shadow which is seen at L2 level. So it could be either be a renal pelvic stone, or it could also be. I would like to take more serious other lateral film to confirm whether it is a stone in the pelvis or whether it is stone maybe in the. It could be in the pancreas also, because that appears in the region of the pancreas as well, or it could be a fecolith or a calcified lymph node.
Yasir has asked whether this is a horseshoe kidney.
No, it's not a horseshoe kidney, sir. It's
It can be, sir.
Why is it not a horseshoe kidney?
So the pelvis appears.
How would be the alignment
on the
of
right
horseshoe
side,
kidney?
the kidney outline is at the normal position. If you see that on the right side, the outline of the kidney is normal. We can appreciate it. Whereas on the left side, the kidney outline is lower. So it's not a horseshoe kidney, because on the right side, the kidney outline is at the normal position.
So in a normal kidney, the upper pole is medial and lower pole is lateral.
Yes, sir.
In horseshoe kidney, it is other way around. The lower poles come medial and upper pole goes lateral. And
Yes,
horseshoe kidney more likely to have a malrotated renal pelvis.
Yes, sir.
Okay, further to call it ectopic kidney probably is not justified.
Sir, a mal-ascended kidney, sir, rather.
You see, you have already said that there is some amount of scoliosis. Okay. So in such situations, you may means some amount of change of position may be seen even during breathing of the patient. So to call it ectopic kidney, I think it needs to be much lower than this. The upper pole is still reaching the 12th rib.
Okay, sir.
Right.
Usually, ectopic kidney is lying over the pelvic bones, not lateral to the spine. One thing. Another thing is it may be just grossly dilated kidney with sagging down compared to the normal side.
Bit of ptotic kidney.
Yeah. And another thing is that opposite side stone also should be commented. And X-ray is not well prepared.
No adequate preparation. Yes.
So that is another thing you can comment.
And there is another implant on the right hand side. There is a hip replacement implant.
Hip implant on the right side. Yes.
Yes. So how will you proceed in such type of patients? What is the presentation?
So the presentation of the patient can be, sir, it can be asymptomatic also. Most commonly it would present with a pain in the right flank region associated with the patient may have hematuria also, sir. Patient may have sir, voiding symptoms also, sir. A patient can also give a history of lithuria, sir, migratory stones. And yes, sir. Yeah. Yes, sir.
Why he has got such a big stone?
Sir, probably, sir, most can probably be because of sir obstruction distally, sir. Maybe pelvic junction obstruction, which has caused urinary stasis and led to this large stone formation, sir.
My dear friend, this is a blunder.
Yes.
Yes.
Okay. Staghorn stones and PU junction obstruction, they don't go together.
Exactly.
Okay.
Okay. Anytime you see a stone that is tightly fitting the PUJ or renal pelvis, don't diagnose PU junction obstruction. Stones with PU junction obstruction will be secondary stones. They will not be sitting at the PUJ.
Right.
So this triangular stone is properly sitting in the renal pelvis. He can have anything but PU junction obstruction.
And without just on one X-ray, you should not make all these comments.
Okay.
And sir is absolutely right. If there is PUJ, it will be nicely balloon system and some nice secondary stones. This is a proper Staghorn.
Again, the Abhishek.
Yes, sir.
Whenever someone asks symptomatology, so we have to categorize inside the mind. So one is asymptomatic. Another is symptoms due to obstruction. So what are the symptoms due to obstruction? It may be pain.
Yes.
Unilateral, bilateral, दोनों साइड को स्टोन है तो दोनों साइड से पेन रह सकते. Pain may be acute, pain may be chronic. ठीक है. Then pain may be associated with vomitings. Pain may be associated with hematuria. Okay. Then the symptoms due to obstruction and infection. So loin tenderness, then fever with change, then bilateral stone, renal failure. So signs of the renal failure. So ये ऐसा categorize करके एक sentence में बोल दिया ना तो examiner को पता चलेगा कि what you are thinking inside your mind. तो asymptomatic symptoms due to obstruction, symptoms due to infection, and symptoms due to renal failure. ऐसा categorize करके अगर दो line बोल दिया तो it will, and obviously if the past stone retention, then lower urinary tract symptoms, these are goes hand in hand. वो भी तो बताना है. ये सब चीजें सीक्वेंस से बताने को आना चाहिए.
Right.
So Abhishek, this patient asked you a question कि डॉक्टर मेरे को इतना बड़ा स्टोन कैसे बन गया और मुझे मालूम भी नहीं पड़ा. What is your answer?
Sir, such a large stone can form because of sir repeated infections also, sir, which can which can form a nidus of stone formation, sir.
अगर infection होएगा तो he will not get pain, he will not get fever, he will not get any other symptom.
The patient might be
asking you, okay, doctor, how come I didn't know? I didn't realize this. I have got such a big stone.
So indirectly, how many % of the patient presented with asymptomatic presentation and Staghorn stone? The sonography done for some another reason. Then say they suddenly found that there is a big stone inside the kidney, but patient doesn't have any symptom. ऐसा हो सकता है?
Yes, sir.
हाँ तो वही तो पूछ रहे हो, explain करना है.
Sir, exact percentage I don't remember. Around 20 to 30% patients may have
25%.
Okay, sir.
Okay, I will ask you direct question. Why there is no pain if there is a stone in the kidney?
Sir, sir, there might not be obstruction, sir, to the urine flow, sir. So there might not be pain because of.
If there is obstruction, Abhishek, it will be probably if it is obstruction inside the ureter, then it will be some colicky type of pain. So dull pain in such type of dull chronic pain in that particular area is usual presentation in such type of patients.
Yes.
Okay, now, so what are the investigations you'll advise this patient?
Sir, investigations I would advise, sir, routine blood investigations, including serum creatinine, sir, renal function tests, and sir, urine routine microscopy, urine culture sensitivity. And sir, I would want to evaluate this stone by doing a non-contrast CT scan, sir.
Why non-contrast?
Why non-contrast?
Sir, depending.
Is this patient is require treatment in some form?
Yes, sir.
So this patient needs some treatment which will be invasive.
Yes.
Because considering the size of the stone.
Yes.
So for doing any invasive treatment for stone, you need anatomical roadmap.
Yes.
Until and otherwise there is a derangement in the renal function. So depend upon the amount of serum creatinine, we have to decide it will be CT-IVP or NC-CTQ. So first of all, I will go for serum creatinine CBC urine routine, and if serum creatinine is normal, I will go for CT-IVP, which will give me a drainage pattern, which will give me size of the stone, amount of hydronephrosis, then function, some clue about functioning kidney or not functioning kidney. And for exact percentage, you can, if you want, if there is a papery thin cortex, then in such situation, we have to go for DTP also. So your answer should be CBC, urine routine, serum creatinine, random blood sugar, urine culture, and after seeing the serum creatinine, I will go for radiological investigation in terms of CT IVP or NCCT QAP. That's what I will. Pankaj sir, is it okay?
Absolutely, sir. Absolutely.
So Madhukar Gupta is asking why Staghorn stones are presented with painless presentation.
Yes, that is what my question is. Why these patients, they come with the Staghorn calculus?
Abhishek, bolo.
Sir, obstruction to urinary flow may not be there, sir. So there may not be association of pain with the Staghorn calculus.
Sir. Talk about the nerve. You're not talking. You're just talking about the obstruction. Why the obstruction is giving pain and without obstruction there is no pain?
Sir,
if someone asks you that when I cut my nail or when I cut my hair, I don't get pain, but when I pull my hair, I get pain. What is the reason?
So innervation, sir.
So talk about that, na?
Sir, because of distension, there may be, sir, stretching of the capsule, sir, which may cause pain, sir, because of.
So then why you are not answering? Why you are talking only of the stretching of the capsule? But when there is no stretching of the capsule, why there is no pain?
Sir, the nerves are stretched, so sir, pain is caused, sir, because of distension, sir. Distension of the pelvic.
Talk about sensory nerves inside the kidney. Are there?
I do not know, sir. No idea. Sir.
No.
Yes, sir. There are the. Yes, sir.
So that is why when you are doing even the puncture in the local anesthesia, the patient gets only pain when you puncture the capsule. It is not a parenchyma. Parenchyma doesn't have. So that is why patient doesn't develop, they don't have pain, and that is why that unless and until the capsule is stretched, he doesn't get pain. So that is why slowly and slowly this stone will become Staghorn calculus. Understood?
Right, sir.
Because it's a very slow process and there is no acute distension of the kidney. Because of the chronicity of the process, patient doesn't get pain. Further, some say mild pains, patient has a tendency to neglect such pains. So every time somebody has a backache, he doesn't go investigating for a stone.
Yes.
So that is why most large stones, rather it means if patient gets pain, the stones will never become this large.
Yes, sir. He will come to the.
They will be treated when it is 4 millimeters and obstructing.
Yes.
Okay. Well, no. So how will you treat it?
Sir, I would explain the patient the condition the patient is suffering from, the need for intervention in this patient, sir, and the natural history. I mean, what will happen if the patient does not undergo treatment? And
if it is non-functioning kidney, then
yes, sir, I will give the I will explain that also to the patient and the options available for the treatment of the stone, and what I am comfortable with, and then, sir, accordingly I will proceed, sir.
So if it is functioning kidney, what surgery will do?
So, sir, if it is a functioning kidney, sir, I would like to go ahead with a PCNL, sir. Either a PCNL if or a staged PCNL, sir. If the stone load does not clear in one sitting, sir. And the clinical and the clinical picture of the patient, sir. How good is he able to withstand the entire surgery in one go, sir?
Now you put a catheter inside and the prank first comes on.
So that's what happened, Abhishek, when you start haphazardly from somewhere else. So you think this patient already during clinical presentation we discussed it. It may be bilateral pyonephrotic obstructed kidney. with or without deranged renal function. Correct? So
Yes,
if it
sir.
is with deranged renal function and pyonephrosis or without pyonephrosis, hydronephrosis also, so we have to divert it first. Either PCN or DJ as per the pyonephrosis or only infected hydronephrosis. So this is the first treatment. Suppose this patient is not having a deranged renal function. Okay, and
Yes.
then we have to go for CTI. Then assess the function, and as per the type function and the presentation symptoms, we have to choose the site because this patient had bilateral stones. Okay,
Yes.
so if the symptomatic and better functioning kidney should be treated
First.
So if it is a right side kidney, then it is either mini PCNL, RRS, whatever it may be as per the size of the stone. If it is left side, then it is PCNL. So PCNL with consent of some residual or 2 track, 1 track, bleeding, blood transfusion, ICU backup, वो पूरा detail बोलना पड़ेगा. If this kidney is not functioning, then nephrectomy. ऐसे 3 division करके अगर तुमने बोल दिया, examiner ने general question पूछा था कि how you go ahead with what is your plan in this patient. So आपने को तो कुछ भी मालूम नहीं है ना कि ये patient का क्या है.
Yes.
So we ourselves has to give the options and answers.
Right.
So in how will you drain this kidney if there is a pus? You like to put DJ stent or you will do PCN?
Sir, I would prefer doing a PCN because, sir, I can use the track later for PCNL also, sir.
Maheshwari ji.
You see, I'm sorry. I'm extremely sorry. In this patient, you see, when there are stones blocking all the calyces, nephrostomy will not be able to drain. One nephrostomy will not be able to drain the full kidney. So your thinking is right that you would put a nephrostomy so that through the same tract you can remove the stones. But more often, these patients should be covered well with antibiotics at least 5 to 7 days before PCNL, and then you may need to make multiple tracts to really drain this kidney. So like in this patient, if I have to do PCNL, I would expect minimum 2 tracts to complete the stone. If I come from upper calyx, that will give me upper calyx, renal pelvis and lower calyx, and I may need a separate tract for middle calyx. So if I have to put nephrostomy tubes in this patient, I would put minimum 2 nephrostomy tubes in the upper and middle calyx.
I agree.
Right, sir.
Only thing is, I think that along with that, even double J stent will help us because there is an obstruction even at PUJ, so the pelvic part may not be able to get. So it may be of some help if you put a DJ stent also. But this is the right answer that whichever is dilated after doing CT scan, obstructed and dilated calyceal system, we should put the nephrostomy in that. Fine. I think we should go ahead with the specimen.
Yes, sir.
Sir, this is a specimen showing sir, kidney and sir, ureter, and so left side of the specimen is showing a kidney and the ureter, sir, and a part of the bladder, I think, sir. And
what is there on the right hand side?
So the right hand side is most probably a stone, sir.
So where this stone was in the left side?
Sir, probably must have been in the, sir, stone appears large, sir, must have been in the bladder, sir, I think.
Bladder? Just see, na? The lower end of bladder.
Nephrectomy.
So can I take this
Yes,
question?
sir.
Yeah,
only,
answer.
sir. Why would do a
answer?
So can I take this?
Yes,
yes,
yes.
sir. So this appears a specimen on nephrectomy. Probably the stone was located in the renal pelvis. Considering the specimen and looking at the stone size, This could be a long-standing stone which might have caused maybe a long-standing stone causing a malignancy. Therefore, the entire cuff of the bladder along with the kidney and the ureter has been removed. So squamous cell carcinoma secondary to a stone.
Where is the
Could
cup
be,
of
sir.
bladder? Where is the cup of
So in
bladder?
the lower part. So in the lower part.
It is not cuff of.
I feel it is only the site of the stone which is
Yes, sir.
dilated, and just distal to the dilated area they may have ligated and removed the ureter proximal to that also. So it is nephroureterectomy up to the site distal to the stone site. I don't see any cup of bladder.
Exactly.
Sir,
You see the lower end of the ureter, and you see the shape of that, and you see the stone. That is why both the this is a clue which has been given to you.
yes, sir.
If I would not have given this stone, and if someone says cup of bladder in this photograph, I can understand.
Another important thing is why they should remove cup of bladder in a patient of stone.
So I was saying a long-standing stone causing a malignancy.
How many ureteric stone will cause long ureteric malignancy, and how many cases you have seen?
So not
To the
seen
best
any
of
case.
my knowledge, I have not read a single report of squamous cell carcinoma due to lower ureteric stone.
So
I will need to recheck
in the
this, but I have not read any such report. There are reports of kidney squamous cell carcinoma related to neglected Staghorn calculi, but lower ureteric stone causing squamous cell carcinoma, I'll need to really look it up.
Now, only thing is,
sir,
I just want to tell one thing before going ahead. Yeah, this patient later on, after 2 months or 3 months, he had lots of problems, and we did the full body CT scan. Earlier, we had just done the renogram and IVP because he didn't have money, and it turned out to be metastatic carcinoma. So I just have to find out whether, because patient never came back to me, I just got the news. Hey, so
metastatic carcinoma, sir. Metastatic
No, I
carcinoma
don't know
from
whether it was a transitional or it is from the, because the report of this lower end of the ureter also came malignant.
So which type of malignancy it is?
That's what the patient never came back to me. I just from the relative I heard.
Sir, also one thing I wanted to ask, sir, the lower part of the specimen on the left side, sir. Sir, there is a abrupt difference between the dilatation and the non-dilated part, sir.
So usually वैसा ही रहता है.
Okay. Right.
Because that particular site is dilated for long years. That particular site looks like a diverticulum. And proximal dilatation, when there is a decompression, it will collapse. So if you see his CT IVP, that proximal ureter also you see dilated and distended. And this is due to the periureteritis and a site of the stone. For longer duration, it will look like a dilated segment. And distal to that, there is a lumen. Okay.
Yes, sir.
At the end, there is a lumen. So right, this configuration will not be there when you have removed the cup of the bladder. So I think in exam you should present it with left right nephroureterectomy along with stone removal.
So, sir, most probably a non-functioning kidney because of
obviously that is the reason they have removed it.
Yes, sir. Got it, sir.
If someone has asked, can it be a diverticulum? See, the primary diverticulum of the ureter is very, very rare. So there may be a dynamic segment, or it can be like, that I have seen that the lower end of the ureter may be like a dynamic, and it can be dilated without any reason. So that is possible, but ureteric diverticulum is very, very rare.
Better not to think eccentrically.
Exactly.
Think in common ways in exam. Everything can be possible. So thinking like ureteric diverticulum, thinking like malignancy, will unnecessarily irritate the examiner and he will go, Baba will go somewhere else. So उधर ही stuck रहना है. Ureteric stone with nephrectomy, उसमें non functioning क्यों हो गया, site of the stone related 1000 questions पूछेंगे वो.
In case if they ask that what are the complications of a long standing stone, then you can answer.
Okay.
Okay. So for this, what is the treatment?
Sir, for this is a case of distal ureteric calculus which has caused back pressure changes and ultimately leading to a non-functioning kidney, sir. So nephroureterectomy is the treatment of choice in this case, sir, because it is a non-functioning kidney.
Okay. Fine. Hiren, you want to ask any question? Mahesh?
No, sir, I think it's well covered.
Well, okay then. No, any other question that can be asked in the exam, then we'll ask them, otherwise we'll go ahead.
We can go ahead, sir.
Okay. So the third set, Paras.
Yes, sir. So just here, this is the X-ray pelvis, well centralized but not adequately exposed, with adequate bowel preparation. The iliac bones are could be seen. The bilateral femur heads are seen, which are normal. In the right, the left-sided inferior pubic rami appears normal. The right-sided, there is a lytic lesion seen in the right inferior pubic rami. Could be suggestive of a osteoblastic or a actually osteolytic mets from a primary malignancy. Or yes, sir, it looks like an osteolytic lesion, sir, from a
So which are
malignancy.
the malignancies that can give rise to such lesion in the bone?
So prostate cancer first, renal cell carcinoma, and so prostate, renal, and sir, so penile cancer, sir. No, so prostate and renal, sir. Prostate and renal, sir.
In urology, prostate and renal, but otherwise it can be a breast also, it can be bronchial,
Yes,
or it can be sometimes thyroid.
Thyroid,
Okay.
yes.
Okay, sir. Yes, sir.
Okay. Fine. So now what are the investigations? This patient has come to you. What are the investigations you'll ask for?
So first I'd like to examine the patient. I'd like to know the age of the patient, examine the patient, do a per rectal examination, DRE, to feel if there is any nodularity of the prostate, which would help pointing towards the primary diagnosis maybe of a prostate cancer. Then I will do an abdominal examination to rule out any mass in the abdomen. After that, if the patient is in the age group of 50 to 70 and has a in that case, and I'm suspicious here for metastatic CA prostate, I will do a serum PSA level and also an alkaline phosphatase. I will like to do, and also I will check the spine for any other spine or any other lower limb weakness or paraplasia or any signs of lower limb, any neuropathic neurodeficiency, to rule out any other metastatic sites. And based on these examinations in the form of a PSA, digital rectal examination, and a clinical examination supported by a sonography, and if required, a further imaging, would help me to clinch the primary. And based on that, if it is I would like to do maybe a bone scan if I am suspicious of other metastasis, to look for other sites of metastasis.
So you will not do the biopsy?
Sir, if the PSA is very high and the digital rectal examination is suggestive of a hard prostate with a very high PSA, then I might not do a biopsy. But if it is in the...
You will not do biopsy?
No, sir, I will do a biopsy. I'll do a biopsy. Yes, I will do a biopsy. I'll do a
there is no
biopsy.
hard prostate. If there is no
Yes,
hard prostate.
So I'll do a trust-guided prostate biopsy if there is a PSA is high and the prostate feels hard.
Suppose if nothing, you are not able to see PSA is also normal, prostate is also normal, and this lesion is there. You have done all other normal investigations. You are not able to find out a primary. Now what will do?
USG, CT both is normal. Okay. Then first a bone scan to look for any other sites of mets, and then if any bone marrow lesion is there,
You
then
want to find out the
primary.
the primary. So for what you will do?
So an FDG PET could be done.
Exactly.
Yes, sir.
That is the answer.
Yes, sir.
Because then you want to rule out any other possibility. And if
Yes,
the
sir.
FDG PET is negative, now what will do?
Then so the if the urology side is normal, then we would like to do.
Still you will, even though you are, because this is the primary, the most important, the most suspicious side will be prostate. So if you are not finding anything, first you will do the biopsy of the prostate. Or you can do PSMA PET test.
Okay.
But the biopsy, I mean, if you are not finding anything, then the biopsy will be done. Okay?
Okay, sir. Yes, sir.
The final thing would be a biopsy from this metastatic site.
Yes. Yeah. But many a times it will just show you the same thing, like, adenocarcinoma or something. And then it may ask for the biochemistry, histochemistry, and then maybe from the prostate.
Yes, sir.
But doctor, what he has said is right. You can take a biopsy from here and it is easier to take. So now what you'll do? PSA is high, prostate is hard, you've taken a biopsy.
Then it comes out to a prostate cancer, then I would like to first do a PSMA PET CT and confirm whether to determine the metastatic burden of the disease, whether it's oligometastatic or whether it is as in there are any other axial skeleton mets as well. Based on that, based on what are the presenting symptoms, then I would like to plan the patient further.
So the place where you are working, there is no PET scan. What will do?
It's a bone scan.
Only bone scan?
Bone scan and CT abdomen plus pelvis.
Not above?
Chest, abdomen plus pelvis. Sorry, chest, abdomen plus pelvis and a bone scan.
Yes. So, yes, that's a CT. So you will go to full body CT scan,
yes,
and then you will like to do bone scan also.
Yes, sir.
Okay. So now you confirm that it is only in this bone and there is no other place there is metastasis. Now what you will do?
So then, if this is a single met and depending upon a single met, so this is the only met, right? So there is no other met. Then I can, yes, sir.
Yeah, right. You are right.
Yes,
only this
yes,
met.
Then I would like to start the patient on androgen depression therapy in the form of this thing, sir, abiraterone.
Only abiraterone?
No, sir. No, sir. As in, first, I would like to start as in a combination abiraterone acetate plus androgen depression therapy in the form of either a surgical bilateral ocherectomy or medical ocherectomy in the form of this thing, sir. LHRH antagonist. Yes.
Antagonist or agonist?
Antagonist, sir. This patient already has meds, so if you give agonist, it can flare up the disease, and it can, if there are any other micrometastasis in the other axial skeleton, it will cause aggravation. So in this case, I will rather start with a
no, it will aggravate the disease or it will aggravate the symptom?
Symptoms, it will aggravate the symptoms.
Then why not agonist? Why you want to start antagonist?
So agonist will cause the initial flare, sir. That's why the symptoms will be aggravated in the initial part.
Is there any way of managing the flare?
By giving androgen receptor blockers, we can use androgen antagonists in the form of bicalutamide or enzalutamide. Yes, sir, we can use that. So agonist, that can be a complete androgen blocker in the form of agonist plus.
If you use,
yes, sir.
See,
Complete blockage of form agonist plus
If you
antagonist.
use agonist,
Yes, sir.
Dr. Gita, you are not audible.
Anyway, antagonist is maybe a choice of drug because it acts very fast and it is a cardioprotective, but it is very costly. And agonist may take 15 days and there may be flare up of the symptoms. Yes. But still, I think most of the urologists, they prefer agonist rather than antagonist. I think most probably because the price is very high.
Okay.
What you said, Dr. Maheshwari?
Yes, sir. I would choose antagonist only when there are metastasis in weight-bearing bones. So if she has associated metastasis in spine or weight-bearing bones or impending retention, then probably there is a place for antagonist. Otherwise, agonists are better because, as sir has said, low cost, 3-monthly schedule, less painful injection. You see, cancer prostate may we, or rather for any malignancy, we also need to consider the financial toxicity.
Yeah. So, what would be your preference, the medical line of treatment or surgical, if the patient comes to you?
So we can offer surgical as well as
We can
medical
offer me,
operator.
what is your choice? What is your choice? And justify it.
So bilateral ureterectomy because it will help to achieve the castration state immediately within the next 24 to 48 hours. So that will help, and then we can support it with either abiraterone or and then maybe add an androgen antagonist as well.
That is one. And not 48 hours.
Yes.
Answer should be like, it is irreversible.
Yes, sir.
Okay.
Yes,
Low cost, rapidly achieved whenever it is required in emergency, like the impending bony fractures वगैरह, spine fracture का कोई issue है. No flare. Prior anti-androgen not required.
Yes, sir.
And but psychologically less preferred.
Oh, yes.
Okay, so why medical? It is reversible. 3 to 4 weeks of time to required for achieve the castration level. Flare is there. So, and in between again there is agonist and antagonist. So whenever you required a emergency castration in short period of time, then you have to go for antagonist because it will achieve the castration level from 72 to 96 hours.
Yes, sir.
In case of agonist, it will require 3 to 4 weeks.
Yes, sir.
There is a flare with agonist, there will not be flare with antagonist. PSA failure with agonist is 14% and PSA failure in case of the antagonist is 8 to 9%. Local injection reaction with agonist is 1% and local injection reaction with antagonist is 40%. CVS wise both are similar and dose is agonist 3 monthly available, antagonist monthly available. So considering the patient in this particular patient, what is better, as per that we have to decide it.
Yes, sir.
It is agonist or antagonist. Then again, same thing for surgical and medical castration. If patient economical condition is good, there is no any emergency to go for the emergency to achieve the castration level, then medical castration. If there is emergency, patient general condition, economical condition is not too good, then surgical castration. Okay.
Yes, sir.
And even the compliance is less. If the patient is staying in small town or small village,
Yes,
he
sir.
cannot come for a regular follow-up. Again, or you may lose him for a follow-up. Again, castration will be preferred.
Yes, sir.
Yes.
Fine. So now this patient has got organ he has got this metastasis, otherwise disease is organ confined, and he is, let's say, 62 years of age. What else you can offer him?
Sir, we'll continue with the androgen deprivation therapy for 6 to 12 months. Then monitor the PSA levels. And if it is responsive,
देखो, again, what examiner is asking? He is asking about the localized prostate with oligometastasis. Correct?
yes, sir.
So, oligometastasis, is it synchronous or is it metachronous? If it is synchronous,
Okay, yes, sir.
then if this much is the metastasis and rest of the body is okay, there is no metastasis. In such situation, what are the options available?
So radiotherapy to the metastatic
Primary
area and to the
radiotherapy or
Yes, sir.
RRP plus radiotherapy.
Yes.
Okay.
Yes,
If the oligometastasis is metachronous,
okay.
then
Then
what are the options?
radiotherapy to the and androgen deprivation therapy.
Yes.
And
So
androgen deprivation to your always
salvage prostate directed therapy or stereotactic body right to the site of oligometastasis. So these are the options for patient having oligometastasis which is metachronous. So whenever he is asking if there is a oligometastasis or metastasis only in that particular area, so we have to divide it into the synchronous and metachronous. If it is synchronous, then RRP, primary RRP plus RRP. This is the option.
Yes, sir.
अभिषेक आग बंद मत करना.
नहीं सर.
Fine. Okay. I think we stop here and go to the last one. That
He
will
is
finish.
meditating on your comments, sir.
Sometimes so much of combination becomes little difficult to like understand, you know. So unless that is why we like to do multiple cases. So if we have got the same series of multiple cases, after 4 or 5 different cases, they can understand what are the different management. Fine. Okay. So all three of you are going to answer one after another. So first we will tell the name and you can answer. So Abhishek, tell us what is this?
Sir, this appears to be most likely a specimen of the kidney, sir, with the sir, with the surrounding fat, sir, and so most, I think, sir, growth can be seen at the lower pole, sir. Sir, the lateral border, sir, at the lateral border, sir, around the lower pole, sir, I think there is a growth, sir. And the rest is the specimen of the kidney with the surrounding.
It's difficult to find out what is the upper pole and lower pole, but you can see the part of the ureter lower down. So
yes,
most this is the upper pole tumor. Yes. So it's a specimen of radical nephrectomy.
Yes.
It's not a classical one, but when they put it into jar and give it to you, it may appear like this. Okay. Fine. Gite sir, please. Can you start the questionnaire?
Sir, if it is a specimen of radical nephrectomy, then it is done. Questions can be asked for what are the indication for radical nephrectomy? One, then what are the probable commonest type of histopathology found in radical nephrectomy specimen? Then, so ये पहले दो तो आंसर करने दो.
Answer दे दे. Abhishek, you answer these two questions.
Yes, sir. Sir, the most common indications for radical nephrectomy will be, sir, a renal mass, most common, sir, a renal mass with a normally functioning contralateral kidney, sir, which is not threatened by stone. I think a renal mass more than 4 centimeter in size, which is not amenable to partial nephrectomy, as in the stone may be lying in between the polar lines, a large mass, and a mass invading the pelvic calyceal system, sir, lying in between the polar lines. Yes, sir. And especially when the contralateral kidney is, sir, not threatened or is normal, sir.
Why not it is a TCC pelvis? Because lower down there is a dilated, something dilated is seen, and ureter is not shown properly in the specimen.
Sir, just by looking at the specimen, I cannot comment whether it is TCC or not, sir.
So
I mean,
how will you differentiate between TCC and RCC? By all means, clinical, radiological, and specimen wise.
So, sir, TCC can, sir, TCC will most commonly present with yes, sir. Sir, TCC will present with hematuria, and sir, cytology will be positive in TCC, sir.
Okay.
And, yes, sir. And radiologically, sir, the mass will be, sir, the majority of the mass will be seen occupying the system, sir, rather than the renal parenchyma. So that way we can, sir, assume that it is a TCC, sir. And of course, sir, yes, sir. Radiologically, sir.
Here, as you
another point is clinical history. There might be a urothelial carcinoma elsewhere. It could be in the bladder. So the incidence of having a TCC in the pelvis when there's a bladder cancer is around 4%, whereas the opposite will be 30 to 70%. So that could be another history. Second would be in the radiological part, we would see that in a transitional cell carcinoma, there will be a papillary growth which will occupy mainly the calyceal system and not occupy the parenchyma. And a TCC grows from central to the periphery, where the renal cell carcinoma will be occupying mainly the parenchyma and will grow from peripheral towards the center. A transitional cell carcinoma will have area of necrosis and multiple clots lying in the PCS system, whereas a renal cell carcinoma would have destruction of the parenchyma and will be more, will initially be more of an encapsulated mass and then progressing from the periphery towards the center.
तुमको थोड़ा सिंपल करके देता हूँ. Clinical presentation, RCC usually present with lumpy abdomen. TCC usually present with hematuria.
Yes.
Then on contrast and CT scan, RCC is brightly enhancing compared to the TCC. Then site-wise, RCC is usually peripheral and exophatic. TCC will be central. As far as PCS goes, RCC distort the PCS and never fill up the PCS. RCC distort the PCS but never fill up the PCS. In case of the TCC, it will infiltrate the PCS and it will fill up the PCS. Okay. And as far as calcification goes, calcification in case of the RCC is central, calcification in case of the TCC is peripheral. So these are the histopathological, radiological, and clinical differentiation of RCC from TCC.
Right.
Okay. So just tell us the renal score. What are the different types of renal score? And mention two in just elaborate two, and then we'll go ahead.
Sir, renal scores include, sir, renal nephrometry scores, or the Padua score. Other minor scores include, sir, centrality index, ABC, which is the arterial based complexity index, DAP, sir, DAP system of scoring, and the zonal nephro score, sir. So the most commonly used two scores are, sir, the renal nephrometry score and the Padua score, sir. Sir, so renal nephrometry score is basically used to define the complexity of a renal mass, sir. Includes variables of radius, radius of the mass, sir, exophytic or endophytic, sir, nearness to the pelvic calyceal system, sir, anterior or posterior, and sir, nearness to the polar line, sir. Sir, on the basis of this, sir, scores are given and the complexity of the mass is decided. So the other commonly used score is the Padua score, sir. Sir, which includes 6 variables, sir, which is sir, polar location of the mass, sir, exophytic or endophytic, sir, the renal rim, Whether it is medial or lateral. Sir, renal sinus invasion is there or not, sir? Sir, and the size of the lesion, sir, and and the involvement and the nearness to the pelvic calyceal system. These are used as the variables of the Padua score, sir.
Good. Very good. So these are the two usually a examiner will ask you. Fine. So shall we go ahead with the last X-ray?
Yes, sir.
Yeah. Paras. Fine. So he's answering now. Amit. Paras, you can just enlarge little.
It is X-ray of KUB region, which is showing lower chest, which ribs are normal, spine is normal, and pelvic bone are normal, and there is a radio opaque shade, vertical radio opaque.
Amit, where is B? Out of KUB, where is B?
The bladder is not seen.
Then why you are telling it is KUB?
Yes, sir.
Okay,
So
these
again,
are the simple point which will check your attentiveness.
Yes, sir.
So whatever it may be, whatever you are seeing in exam, you have to tell that only.
Okay.
Let examiner check where is the B, then what is by normal QB, from which place to which place. उसका आंसर करे वाला अच्छा रहेगा ना, अपन क्वेश्चन प्रोवाइड करना का एग्जामिनर.
Yes, sir.
so again start. This
is X-ray showing lower chest and lumbar and thorax, lower thorax.
and the abdomen. Don't talk about pelvis. Or you can say that lower chest and upper pelvis. Still lower chest to upper pelvis. Upper part of the pelvis. Nothing else. Okay. Go ahead.
Yes, so there is rib cage is normal, spine is normal, sacrum and iliac bones are normal, and there is a radio opaque opacity at the level of L3 transverse process. Most probably it is upper ureteric stone, or
Okay.
it might be calcified lymph node or FACULTIES.
So you tell us the surface marking or radiological marking on X-ray
Yes.
about the ureter.
The ureter passes lateral to the transverse process of the spine. Then it
Where? L1, L2, L3, L4, L5. From where it starts?
from L2, L3 level it will start and passes down up to the L5 level, and then crosses laterally at the sacroiliac joint, and then passes again medially to in the pelvis and drain into the bladders.
So how you divide the ureter?
Sir, upper, middle, and lower, sir.
So tell us on X-ray.
Sir, upper ureter is from L2 level to the sacral bone. Then middle ureter is from area occupying the sacroiliac joint, and lower ureter is from the lower border of the sacroiliac joint to the bladder.
So area below the inferior border of sacroiliac joint is a lower ureter. Between the superior and inferior border of sacroiliac joint is mid ureter, and above the superior border of sacroiliac joint it is upper ureter. These are the radiological classification.
Yes.
Then anatomical classification.
Anatomical classification from the pelvis to the abdominal ureter is
Above the iliac crossing, it is upper ureter, and below the iliac crossing, it is lower ureter.
Is a lower. Yes.
Understood?
Yes, sir.
Okay. Fine. So what investigation you will do to find out whether this is a ureteric stone or not? One of the simple investigation.
Sir,
lateral X-ray, plain X-ray
Okay.
lateral view, sir.
Yeah. So lateral. Now, if you want to prove that it is the ureteric stone or the, so what special test you will do?
the non-contrast CT KUB, sir.
So the easiest test is saying ultrasonography KUB. You agree?
Sir, all ureteric stone cannot be picked up by the USG, sir.
So the percentage?
The USG is not sensitive for the lower ureteric stone, particularly. And see, all the ureteric stone can be seen in the CT, non-contrast CT KUB.
Fine. So you like to do non-contrast or with contrast? Which is preferred?
Non-contrast CT KUB is preferred, sir.
And then once you remove the stone and after 2 years, the kidney is not functioning. Patient comes to you saying that you did a surgery on me and now it is non-functioning kidney. How will you justify?
In the non-contrast CT KUB, the parenchymal thickness also can be seen, sir. So if the parenchyma is thin, then we can go ahead with the functional scan like DTPA. If thickness is not thickness is less or hydronephrotic kidney, sir.
Friends, I have one small suggestion for you. From exam point of view, you see, Amit, what you are saying may make a sense. It may be what some people would do, but from exam point of view, just say that if creatinine is normal, I would do contrast CT.
Okay.
You will never come in problem for saying contrast CT when creatinine is normal. But if you say plain CT, you are likely to get trapped into this discussion.
Okay.
Nobody can fault you for doing one extra contrast CT.
Yes.
Okay. फिर एग्जामिनर अगर आपको रिवर्स पूछता है वो बात अलग है, बट अगर क्रिएटिनिन नॉर्मल है, सजेस्ट contrast CT.
Okay.
Dr. Gite, you will agree with me?
Yeah, 100%. Because if you go to see, I agree with you. And couple of times it has happened. Patient has come back to me. We have not done any investigation, done just ESWL. And now, that time it was hydronephrotic kidney. And now it is not functioning properly. Your details become small. Patient will come and fight with us. So I think that if any contraindication is there, is okay. Otherwise, advice, and at least in exam, we can always say that with the contrast, I will do the CT. We will, as you say very rightly.
In spite of telling Amit one-liner, whatever you are telling is you have to defend it. If you are telling it is NCCT KUB, then as per the guidelines, the gold standard investigation for any ureteric stone presenting with colic is in emergency setup is non-contrast CT scan. Agreed?
Yes,
in acute colic setup. If this patient is presented to you with a colic, then NCCT QB is a most theoretical answer.
Yes.
If you want to see a CT scan IVP, then if serum creatinine is normal, I will go for CT IVP. Then you have to that also justify. But I want to know the anatomical roadmap. I want to know the proximal hydronephrosis. I want to know the drainage across the stone. I want to know the dilatation of the calyces. I want to know the parenchymal thickness. ये सब चीजें एनसीसीटी में भी मिलती है, इधर भी मिलते हैं, सिर्फ फंक्शनल स्टेटस देख फंक्शनल स्टेटस छोड़ के,
Yes.
ठीक है। तो मुझे लगता है कि वो पर्टिकुलर पॉइंट पे एग्जामिनर का क्या ये है, मूड है, वो हिसाब से। और पेशेंट अगर कोलिक में प्रेजेंट किया है तो एज पर द गाइडलाइंस इट इज एनसीसीटी के।
Yes.
Yeah. Fine. Okay, so you found out that there is a stone in the ureter. What you will offer?
Sir, according to the condition of the patient, if patient is in the sepsis, then I will first divert the urine by putting the degestant or PCN. Or if patient is non-febrile and count is normal and create is normal, then I will offer him from the ureteroscopic removal of the stone with the lithotripsy, or explain the patient there is a chances of migration of the stone in the pelvis and need for the RIRS or PCNL.
Pankaj bhai, you want to ask any question?
So, Amit, whatever you said was very good, except don't say PCNL for such a small stone.
Okay, sir.
It is too small for PCNL. Okay, if it suppose gets pushed back, why can't you just give ESW?
Yes, sir.
So, and you know, it is in our situations that we segregate URS and flexible ureteroscopy. But theoretically, by literature, even flexible ureteroscopy is ureteroscopy.
Yes.
So you say your plan of treatment will be ureteroscopy. You will attempt start with rigid ureteroscope first. If it gets pushed back, I will have flexible ureteroscopy ready. I could even use ESWL for this as a second option.
Okay.
Agreed.
Yeah. Fine. I think on X-ray, I have nothing more to be asked. Correct?
Absolutely, sir.
Yes,
So I
sir.
think they are doing quite well. Of course, we will continue different things now. CT scans and other things, we will take it over. Now, only thing is, please tell your suggestions whether you people want on Friday or
want
only
on
you
Friday.
want to continue on
So we
Tuesday.
want on Friday, sir. We
Sir,
want on
please, sir, Tuesday and Friday both, sir.
Tuesday,
Yes,
Friday
sir.
both would be preferable. Yes, sir.
Till the
Okay,
exam,
then-
sir.
Okay, so in the group, please give all of you give your suggestions. Please participate in at least in giving the suggestion. Okay,
Okay,
and
Okay, sir.
we'll do accordingly. Fine.
Yes, sir.
Yes, sir.
Fine.
Thank you, sir.
Very good.
Thank you so much, sir. Thank you, sir.
Thank you, sir. Thank you, Gaurang Shah, sir. Gite, sir. Thank you,
Thank
sir.
you, Gaurang sir. Thank you, Gite,
Thank
sir.
you, Maheshwari, sir. Thank you, Hiren Sodha, sir.
Good night, everybody.
Good night, sir.
Good night, sir. Thank you,
Good
sir.
night, sir.
Good night, sir.
Good night.
Good
Thank
night,
you, sir.
sir.